Greetings all. Today we are going to discuss thyroid disorders for a family medicine physician. We are going to start with the more common thyroid dysfunction, that is hypothyroidism. First, we are going to define hypothyroidism. So hypothyroidism or primary hypothyroidism is defined as having a high TSH, and according to the status of free T4, we have a specific classification for primary hypothyroidism. So if the TSH is high and the free T4 is low, this is called overt hypothyroidism. If the TSH is high and the free T4 is normal, this is called subclinical hypothyroidism. And subclinical hypothyroidism is further subclassified into 2 degrees. If the TSH is high but less than 10, this is called mild subclinical hypothyroidism. And if the TSH is high but reached 10 or more, this is called severe subclinical hypothyroidism. So we either have overt or subclinical hypothyroidism, and subclinical hypothyroidism is further subdivided into mild or severe subclinical hypothyroidism. How common is hypothyroidism? So the reported prevalences for hypothyroidism range from 4.6 and up to 8.9% of the general population. And this is a tremendous number because actually hypothyroidism is considered to be the second most common endocrine dysfunction following diabetes. For all patients who have hypothyroidism, around 11% do have overt hypothyroidism, and the remainder, 89% of the patients, is having subclinical hypothyroidism. Among patients with subclinical hypothyroidism, only 20% exceed the 10 microinternational unit per mil, classified as being severe subclinical hypothyroidism, and the remainder 80% would be classified as mild subclinical hypothyroidism. So hypothyroidism is a common disorder. However, most probably it would be subclinical, around 9%, 90% of the patients, and most of the subclinical hypothyroidism is in the mild form, 80% of the patients. As you can see, in all age groups, females are more affected compared to males. And if we are going to remember one number of how common females are likely to develop hypothyroidism compared to males, this is going to be 10 to 1. And the second observation is that you can see that with increasing age, the prevalence increases until we reach the oldest age group, where you can see that 1 in 6 older patients, older males, and 1 in 5 older females may have hypothyroidism. The common etiologies, definitely the most common cause of hypothyroidism would be Hashimoto thyroiditis or autoimmune thyroiditis. And the second most common would be iodine deficiency hypothyroidism. Other causes may include congenital hypothyroidism. Hypothyroidism may be iatrogenic due to surgery or due to irradiation of the neck, and other causes may include postpartum thyroiditis or de Quervain thyroiditis or other types of thyroiditis, including drug-induced thyroiditis or radiation thyroiditis. What would be the history we should expect to hear from a patient presenting with hypothyroidism? So the American Thyroid Association recommends that whenever you hear any of these 7 symptoms, you should consider the differential diagnosis of hypothyroidism in your patient. Starting with cardiac dysrhythmia, or better to say palpitations or awareness of heartbeats, constipation, dysmenorrhea, or better to say any menstrual irregularity, malaise and fatigue, weight gain, change in skin texture, and alopecia. However, we have to remember that hypothyroidism has a certain limit of reliability. So actually, you may find some patients who present with multiple of the so-called hypothyroid symptoms without having the disease. Actually, this represents 17% of the healthy population. So you may encounter 1 in 6 healthy general population that may complain of several hypothyroid symptoms without having hypothyroidism actually. And on the other hand, or the other extreme, you may find a patient with overt hypothyroidism with a TSH that's elevated and a free T4 that is subnormal. However, 30% of such patients may completely lack symptoms. So you may encounter a patient with overt hypothyroidism without having any symptoms to present to you, and so you will not be able to screen such a patient. That is why to pick the 30% patients who have overt hypothyroidism with complete lack of symptoms, we should resort to screening. Who should be screened? Actually, any patient with a goiter should be screened. Any patient with positive autothyroid antibodies should be screened. All females after reaching the age of 30 should be screened, and if the initial screen is negative, it should be repeated every 5 years. All obese patients should be screened for hypothyroidism because in such a population, 14% of obese patients do have hypothyroidism. A patient with established autoimmune disease should be screened for autoimmune thyroid disease, examples of which include type 1 diabetes, Addison, hypoparathyroidism, pernicious anemia, and vitiligo. A number of drugs may actually induce thyroid dysfunction. This includes lithium and amiodarone, and so patients who are on regular use of such medications should be screened for thyroid dysfunction. All infertile females should be screened for hypothyroidism, and all pregnant females starting from the third pregnancy should be screened for hypothyroidism. A patient with history of head and neck irradiation should be screened for hypothyroidism, and a patient with history of hemithyroidectomy or subtotal thyroidectomy should be annually screened for hypothyroidism. The most important indication to screen a patient would be first-degree family history of thyroid dysfunction or autoimmune thyroid disease. A patient presenting with 4 neuropsychiatric symptoms, that is anxiety, depression, dementia, and myopathy, should be screened for hypothyroidism. 2 chromosomal disorders, they do have increased risk of having autoimmune thyroid disease. This includes Down syndrome and Turner syndrome. Any patient living in an iodine-deficient area should be screened for hypothyroidism. We should remember that Egypt is not iodine deficient because the government has adopted the program of iodization of salt starting from 1996, almost 30 years ago. So 90% of Egyptians are classified as being iodine sufficient. And the last 2 indications to screen a patient for hypothyroidism would be type 2 diabetes and hypercholesterolemia. For the clinical examination, there are certain signs that should not be missed while you are examining a patient with a possible diagnosis of hypothyroidism. First, we should expect that the skin would be rough due to hyperkeratosis. And if the hyperkeratosis is severe enough, you would actually notice scales covering the skin. This is called acquired ichthyosis. You would expect that these patients would have a thick skin because they have the so-called generalized myxedema. A patient with hypothyroidism may present with pallor because hypothyroidism may be complicated by a number of causes of anemia, like normocytic normochromic anemia of chronic illness, microcytic hypochromic anemia of iron deficiency, and macrocytic megaloblastic anemia of B12 deficiency. A patient with hypothyroidism may present with yellow or orange discoloration of the skin due to hypercarotenemia, and a patient with hypothyroidism may present with vitiligo because vitiligo is an autoimmune disease that may associate Hashimoto thyroiditis. The skin of a patient with hypothyroidism is expected to be dry due to a decrease in the sympathetic nervous system activity. A patient with hypothyroidism may present with abnormalities in the hair in the form of madarosis or loss of upper 1/3 of eyebrow, a diffuse hair loss or a localized hair loss like alopecia areata, like you can see in the picture. And a patient with hypothyroidism may present with carpal tunnel syndrome due to compression of the median nerve behind the flexor retinaculum due to compression by the myxedematous tissues. In a patient suspected for hypothyroidism, how do you screen or how do you confirm? By lab. We follow a 2-step approach. First, you start screening by ordering the TSH. Only patients who have a TSH higher than normal, higher than 4 microinternational units per liter, would qualify for the next step. The next step would be ordering the free T4, because the free T4 is going to help you classify your patient into either having overt or subclinical hypothyroidism, a mild or a severe form of subclinical hypothyroidism. And in the second step, you are allowed to order additional tests to clarify the etiology of the hypothyroidism. For example, you may order thyroid autoantibodies to confirm if the patient's having Hashimoto thyroiditis, yes or no. The imaging actually may help you differentiating different etiologies of hypothyroidism. For example, if you can see here, the thyroid on the left panel is the normal thyroid. As you can see, normally the thyroid is echogenic, or you may say hyperechoic in relation to the strap muscles or the pretracheal muscles. While on the right panel, you can see a thyroid affected with autoimmune thyroiditis or lymphocytic thyroiditis, where you can see that the thyroid is severely hypoechoic and filled with hyperechoic fibrosity. So actually, the left panel is a characteristic picture of a patient with autoimmune hypothyroidism. So the ultrasound may actually clarify the etiology of the hypothyroidism. Who should be treated? We actually should treat all patients who have overt hypothyroidism. However, when it comes to subclinical hypothyroidism, some of the patients would benefit from the treatment and some will not benefit from the treatment. So actually, they have found that a patient with subclinical hypothyroidism with a TSH 10 or more is at a greater risk of having coronary heart disease morbidity and mortality and heart failure morbidity. So it is recommended that patients with severe subclinical hypothyroidism with a TSH 10 or greater should receive levothyroxine treatment. However, for patients with mild subclinical hypothyroidism, only selected patients would benefit from the treatment. This includes patients who are pregnant. This includes patients who are seeking fertility or patients who are infertile and patients who are at greater risk of progressing to overt hypothyroidism. And this can be predicted by the presence of a sizable goiter or having a markedly elevated antithyroid antibodies. How should we treat? Definitely, we should treat with levothyroxine or T4. Why specifically? Because levothyroxine is effective, safe. It has very long-term experience. It has a long half-life, which means stability. It is having a low cost with good intestinal absorption, and it would be easily administered. How should we take or administer levothyroxine? It should be taken on an empty stomach, right immediately after the patient awakes from sleep. It should be separated by 60 minutes from any food, beverages, or other medications. An interesting fact about levothyroxine is that it has a very long half-life, 7 days of half-life, and the implications would be two applications. The first application is that in order to judge the efficacy of a drug, it has to spend at least 6 half-lives. This means that the first visit after initiating levothyroxine should be 6 to 8 weeks later. And second, if a patient misses a dose, it should be made up on the next day. What would be the target of treatment? According to the age, if you are dealing with a patient less than 70 years of age, so your target should be bringing back TSH back to 0.3 to 4. If you are dealing with a patient who is elderly, 70 years or greater, your target should be to render the TSH 1 to 5. However, in certain contexts, you may actually choose a different target. For example, if you are dealing with a pregnant woman, you should target a TSH of less than 2.5. And if you are dealing with a patient with papillary thyroid carcinoma with a high risk of recurrence, you should target a TSH of less than 0.1. How to initiate treatment? For a patient with overt hypothyroidism, we give full replacement therapy. We calculate the dose by multiplying 1.6 micrograms per kg body weight of the patient. However, so for subclinical hypothyroidism, because this is a milder form of hypothyroidism, we use a lower range of levothyroxine dosages. As you can see here in the American Thyroid Association, usually you would need a dose ranging from 25 to 75 micrograms per day, and you may choose or you may use the TSH at the time of diagnosis as your guide to initiate the treatment. So if at the time of diagnosis the TSH is 4 to 8, you may initiate levothyroxine at 25 micrograms per day. If it is 8 to 12, 50 micrograms per day, or if it is greater than 12, you may initiate levothyroxine with 75 micrograms per day. However, you may actually use a lower initial dose in specific circumstances, like if you are dealing with a patient who have established coronary heart disease, you should start with a low dose of 25 or maximum 50 micrograms per day. If you are dealing with an elderly patient, you should start with a low dose of 50 micrograms per day. And in other situations, you may actually choose to start with a higher initial dose, like patients in pregnancy. Actually, pregnancy is a state of increased levothyroxine requirement, and that's why we use a much higher factor to calculate the initial dose. Or if you are dealing with a patient with papillary thyroid carcinoma with a high risk of recurrence, in order to achieve a suppressed TSH, you have to initiate the dose using a much higher factor compared to the 1.8 or 1.6 that we have mentioned. So that's it for the first thyroid dysfunction, the hypothyroidism. Now we are starting with the second thyroid dysfunction, the hyperthyroidism, and we start with the definition and classification. So like we have classified primary hypothyroidism into overt and subclinical, we actually use the same classification here. So we start with a subclinical hypothyroidism, where we have a suppressed or undetectable TSH with a normal free T4. Overt hypothyroidism, where we have a suppressed or undetectable TSH with a high free T4. Or in 2 or 3% of the patients, the patient may present with what we call T3 toxicosis, where we have suppressed or undetectable TSH and normal free T4, but a high free T3. How common is hyperthyroidism? Actually, compared to hypothyroidism, it is much less common. So for the overt hypothyroidism in Europe, it is estimated to represent 0.5 to 0.8% of the general population. In USA, it has been estimated as to represent 0.5% of the general population. For the subclinical hypothyroidism, like subclinical hypothyroidism, which is more common compared to overt, also the prevalence of subclinical hypothyroidism is much more common compared to overt, with 1.8% of the general population. How about the etiology? The most common etiologies of hyperthyroidism include Graves' disease, toxic multinodular goiter, or toxic adenoma. Definitely for the Graves' disease, it is the most common cause of hyperthyroidism in patients in areas of iodine sufficiency. It actually represents 80% of all patients of hyperthyroidism, while in iodine deficient areas, toxic multinodular goiter and toxic adenoma, especially in elderly patients, may represent up to 50% of patients presenting with hyperthyroidism. So these are the 2 or 3 most common causes of hyperthyroidism. However, we have rare causes of hyperthyroidism, like these 2 causes. In these 2 causes, we have a stimulation of the TSH receptors, either by a TSH producing adenoma of the anterior pituitary, thyrotropin-induced thyrotoxicosis, or due to excessive production of HCG, which has a specific low affinity for TSH receptors. However, because of the huge amounts produced by trophoblastic tumors, it may actually stimulate the thyroid to secrete thyroid hormones. So actually, these are 2 causes of hyperthyroidism. However, they are quite rare causes. We also have causes of thyrotoxicosis, where we have high levels of circulating thyroid hormones without actually having a hyperfunction or increased production coming from the thyroid. So we have the thyroiditis, the most common of which would be the subacute thyroiditis. We have the postpartum or silent thyroiditis, and we have the drug-induced thyroiditis, with the most famous cause would be amiodarone and interferon alpha. Here we have destruction of thyroid follicles and the release of preformed thyroid hormones. This actually creates an increased circulating levels of thyroid hormones without actually having an increased production of the thyroid hormone. Also, another cause of thyrotoxicosis would be exogenous thyrotoxicosis. And we have also the ectopic hyperthyroidism, which may come from functional thyroid cancer metastasis, or in rare cases of stroma ovarii. How would a patient with hyperthyroidism present? So the common symptoms occurring in more than 50% of the patients would include palpitations, fatigue, heat-related symptoms like heat intolerance and increased sweating, weight loss in up to 60%, 65% of the patients, and tremors. These are the common symptoms. The less common symptoms include disturbed sleep, gastrointestinal symptoms like hyperdefecation or diarrhea, and menstrual disturbances in women, mainly in the form of oligomenorrhea or amenorrhea. The rare presentations would include weight gain occurring only in 10% of the patients, pruritus, apathy, and depression. For the clinical examination, a goiter is a common presentation in patients who have a hyperthyroidism. However, there is a certain distinction between patients who are younger than 60 years of age or older than 60 years of age. So it is a common presentation in patients who are younger than 60 years of age, and up to 94% of the patients will present with a goiter. However, for older patients, it would be present only in 50% of the patients or less. A patient with hyperthyroidism may present with a tender thyroid. Remember, the differential diagnosis of a tender thyroid would include the most common, the subacute thyroiditis, suppurative thyroiditis, painful chronic thyroiditis, amiodarone-induced thyroiditis, malignant neoplasm of the thyroid, hemorrhage into a thyroid nodule, or a painful Graves' disease. Atrial fibrillation is actually a rare complication in patients who are younger than 60 years of age, representing less than 3% of the patients. However, in patients who are older than 60 years of age, it may occur up to 13% of the patients. Definitely, if you are dealing with a patient with Graves' disease, they may present with extra thyroidal manifestations in the form of Graves' orbitopathy, dermopathy, or acropathy. So orbitopathy is estimated to occur in 20 to 40% of the patients with Graves' disease. In 5 to 10% of these patients, they may have accompanying dermopathy, and in about 20% of patients with dermopathy, they may be complicated with acropathy. How about the investigations? Apart from the thyroid function test, we have already classified hyperthyroidism. In every patient with hyperthyroidism, you should order a TRAP or TSH receptor antibodies. If this is positive, this is Graves' disease. If it is negative, you should consider other causes, including toxic multinodular goiter, toxic adenoma, or a thyroiditis. An ultrasound is a very important investigation to support the diagnosis. When do you order a thyroid scan? Only if the ultrasound reveals a nodule that is 2 centimeters or greater in size. How about the treatment options? You should offer your patients the choice of one of 3 treatment lines, starting with the medical treatment. So for the medical treatment, initially you should offer your patient beta-adrenergic blockade, because actually beta blockers has an instant mode of action, and it would control most of the hyperthyroid symptoms, and this would allow time for the antithyroid drugs, which takes 2 to 3 weeks to kick in for the patient to feel relieved. For the medical treatment, according to the latest guidelines issued in 2018, medical treatment should be the treatment of choice, and it should be offered to all patients presenting with new onset Graves' disease, and radioactive iodine or thyroidectomy may be considered only in patients who consider this as an initial treatment. What should be treated? What should be used? Methimazole, which actually we don't have in our country, or a carbimazole, which is more available in our country, should be used in every non-pregnant patients, because propiothyroxine is only preferred during the early 1/3 of pregnancy, and after the finish of the early 1/3 of pregnancy, we actually go back to carbimazole. How long should it be should it be used? We initially use it for 12 to 18 months. And if the patient after this period have a normal TSH and a normal TRAP, it should be stopped. For a patient who still have persistent suppressed TSH or persistently high TRAPs, we may extend the treatment duration for another 12 months, or we may ask the patient to choose between radioactive iodine ablation or thyroidectomy. So actually, the European Thyroid Association recommends that before stopping the antithyroid drugs, we should actually measure the TSH receptor antibodies, because if it is positive, it will predict a relapse of the disease. Do not stop the antithyroid drugs unless the patient becomes negative for TRAB. The second option would be radioactive iodine ablation. Remember that before administering radioactive iodine ablation, a pregnancy test should be ordered 84 hours prior to treatment, because administering radioactive iodine in a pregnant female may actually cause serious risks to the patient and to the fetus. What would be the dose usually administered for a patient with Graves' disease, for example? We usually administer 10 to 15 millicuries of radioactive iodine. And actually, this dose is expected to produce hypothyroidism in 74 and up to 81% of the patients. So this is the efficacy of radioactive iodine ablation, which means that we have a failure rate of about 20%, which may require a second dose of radioactive iodine ablation or a choice for another ablative therapy. When do we follow up our patients? Actually, the first follow-up would be within 1 to 2 months, preferably after 6 weeks of administration of radioactive iodine ablation. Usually, it takes from 4 to 16 weeks for the effect of radioactive iodine ablation to kick in. Actually, the full evaluation of the effect of radioactive iodine ablation should be within 6 months. So it is not before 6 months that you would evaluate if the dose was successful or not. So I have mentioned that we have around 20 or 25% failure rate. And so if the patient after 6 months of administering the radioactive iodine still hyperthyroid, you may actually administer a second dose, or you may ask your patient to choose for another ablative therapy. The last of the treatment options is the surgical treatment. And actually, in all practicing endocrinologists around the globe, whether this is United States or Europe or Asia, usually the least preferred choice for the treatment of Graves' disease would be the surgical treatment. So what are the advantages of surgery? Definitely, it produces rapid control of hyperthyroidism with no recurrence of hyperthyroidism if the chosen procedure would total thyroidectomy. It has no detrimental effect on the course of Graves' orthopathy, and definitely no radiation risk. However, it has certain disadvantages because patients may suffer from the complications of thyroidectomy in the form of postoperative hypoparathyroidism or recurrent laryngeal nerve palsy. Definitely, it has the most significant costs. It requires hospitalization. It may produce permanent scar, and definitely, if we may consider this as a complication, it would lead to permanent hypothyroidism. So if we compare the surgery compared to medical treatment, we have a chance of achieving remission, and the patient would spend the rest of his life without medications and in euthyroidism. And so what would be the indications to consider the surgical treatment for patients with hyperthyroidism, specifically for Graves' disease? The indications would be the patient's preference, as we have mentioned in the first recommendation. So some patients would prefer going to surgery. If the patient has concomitant hyperparathyroidism, then the surgery would be the choice for the hyperthyroidism and the hyperparathyroidism. If you have confirmed malignancy or high suspicion of malignancy, if the patient is suffering from compression symptoms, if the patient presented with intolerance to antithyroid drugs, preventing the continuation of the antithyroid drugs, if the patient is planning a pregnancy and there would be a risk of resorting to radioactive iodine ablation, and there would be a risk of using antithyroid drugs during pregnancy, and finally, during childhood, thyroidectomy would be considered the ablative treatment of choice compared to radioactive iodine ablation. So this is the end of our presentation. I hope that the lecture was informative, and best of luck for all of you. Thank you.